Hello and welcome to another Pype Pods. Today we're going to continue the cardiac theme and we're going to talk about lead 2 interpretation. Okay, a lot of people have trouble looking at ECGs, understanding what it is, so it's my hope to maybe shed some light into what to look for and what's actually happening with the heart. Because it's all well and good being able to read an ECG, but if you don't know what's happening in the heart and what to do about it, then it's kind of pointless. So we'll get stuck in a picture that everybody knows and love. This is the electrophysiology pathways that you find within the heart. So, well-known fact, the sinoatrial node up in the top left corner is the main pacemaker of the heart. That's where a contraction is supposed to start. Okay, so when we looked at the conductivity before this lesson, the actual conduction of myocardial sites, it's the sinoatrial node that you want it to start at if you're going to get a sinus rhythm. Okay, from there you get an impulse. Okay, action potential comes through, and because of the excitability and contractility of the myocardium, you'll get the spreading of that. Now, if you see the arrows coming out both down and to the right of the screen, that's essentially where the impulse spreads to. So it spreads across the atrium and then down to the AV node at the same time. So there's a slight delay, but as we'll learn soon, very, very minor. Once it gets to the AV node gets activated, okay? Because then that picks up its action potential and it sends an impulse down the bundle of hysts and around to the Purkinje fibers, and that's what causes the ventricle contractions. Okay, now if you remember the last lesson we talked about hearts, we know that the heart muscle and the heart itself is very special, unique in a lot of ways. So it has what's known as automaticity, which means the SA node, the AV node, the bundle of hysts, and the Purkinje fibers have their own inherent conductivity. So even with the absence of any impulses, they will continue to beat at their own rate. It also has the ability to contract with the conduction, and it's excitable, meaning it can be influenced by an impulse, and that is every single cardiac cell, okay, not just the SA and AV node. So when we start talking about arrhythmias, it's good to know that every cell has the potential within the heart to generate a contraction, and from that cell you'll actually have a conduction pathway to the cells surrounding it. Okay, so it's not just the SA node and the AV node pathways that can pass on this conduction, it's any cells within the myocardium. If they get activated, then they can pass on the conduction pathway in the opposite direction or a completely different direction. The way we read the effectiveness of the heart, or how well the heart is releasing electricity or contracting, is by using ECG papers. Okay, now things that we need to know about ECG papers is the way that they're broken up. Now I'm sure everybody's fully aware of how an ECG paper is broken up, but we'll just go along just so it makes it easy to refer back to for the rest of this pod. So if we work along the bottom axis, you'll see that that's a generation of time. And if you look at the large squares, or 5 little squares, that's 0.2 of a second, meaning that 5 large squares represents a second in time, and every little square represents 0.04 of a second in time. Now moving up the vertical axis, we have millivolts. Okay, now that is our measurements of current. Okay, so when we're looking at millivolts, we're looking at how much current is actually passing through the myocardial muscle in order to generate that contraction. Okay, so that's what we're looking at. Obviously we have different rules of how much millivolts is normal, how much time the contraction should take, and that's an easy way to generate what's normal and what's abnormal. Okay, so referring back to this ECG paper, we'll move on to the steps of interpreting an ECG. Okay, so when we look at our waveform, nice and easy waveform. This is a beautiful waveform, very rarely seen. Okay, and it's essentially what you'd hope to see on our lead 2. Okay, so we have a P wave, a QRS complex, a T wave, and sometimes you have what's known as a U wave. P wave itself is the depolarization of the atria. Okay, so this is what happens when the SA node is initiated and the impulse is passed across the atrium and down to the AV node. The reason we get that nice curved morphology is because of the way it travels from the SA node around the atrium, both atrium. So if you were to break the P wave down, and you could see both individual, the right and the left atrium contracting themselves, you will see two peaks and troughs. Okay, but because they're joined together at the same time, you should see a nice rounded and upright curve of the P wave itself. Okay, now the duration of the P wave shouldn't be any bigger than 3 squares, so 0.12. Okay, what often happens is people will often look at what's known as the PR interval instead of the P wave when looking at time. When we look at that PR interval, it essentially means from the very start of the P wave to the very start of the QRS. Okay, so PR interval is essentially a way of determining from your very first action potential in the SA node, the time in which it takes for that to travel to the AV node. Now, if they could be represented on this, the SA node will actually be instigated just before the P wave will start. And then you'll see the P wave by representation of the myocardial millivolts of the atrium. And then just before the P wave comes back down, or peaks and then drops, you'll actually begin to see the instigation action potential of the AV node before it moves into the QRS complex. Okay, so the PR interval should be between 0.12 to 0.2 seconds. Now, if it's longer, then that's an indication of the AV blocks. When we move to the QRX complex, that is your ventricles depolarizing. Okay, so this is the main muscle depolarizing, which means we have the biggest amplitude. The biggest amount of millivolts will be released during the myocardial depolarization because it's the largest muscle mass within the heart. Okay, it should be normal is anywhere between 1.5 squares and 3 squares. Now I'm talking little squares, obviously, when I say squares. So it's quite thin because it's a very quick depolarization, very quick peak. Okay, now when the QRX complex is wider, it essentially means that either the contractions come from a different area, okay, so it's not coming from the AV node. You've got a bundle branch block, so you've got a slowing down of the actual travel down the bundle branch itself. Okay, so that's what happens when you get a widened QRX complex. Now, at the same time that the QRX complex is going through this ventricle depolarization, you're also getting atrial repolarization, but the millivolts aren't large enough to see. Okay, so it just gets soaked up by the QRS complex. Okay, ST segment essentially means the area between the end of depolarization and the start of repolarization. Okay, so this is represented by your phase 3 when you're dealing with your conduction. Okay, so it's a phase 3, so how well the heart is sort of in that stabilizing phase before it moves into the repolarization side of the house. Okay, so that's what this area represents. Now, we're not really interested in how long or how much amplitude it has. The main thing we look at when it's dealing with the ST segment is whether or not it's above or below what's known as the isometric line. So the isometric line essentially means if you have a look at the line before the P wave and you have a look at the line after the T wave, then the ST segment should be at the same millivolts as those lines. Now, if it's different, then that's essentially denotes some form of myocardial damage. So generally speaking, if the ST segment is elevated, meaning higher than that general isometric line, then you're dealing with myocardial injury. Okay, so the heart is at risk of dying. If you have depression, so it's actually below the isometric line, then the heart's already dead. That aspect of the heart, anyway, not the whole heart, but aspect of the heart is already dead. Okay, now it's not just your acute coronary syndromes that can cause this sort of thing. You can also have things like pericarditis Some people have extremely large left ventricles because your heart has to work harder in order to deliver oxygen to your body over a long period of time. You get what's known as left ventricular hypertrophy. It also could be caused by pulmonary embolus and then your electrolyte imbalance, as you could imagine, okay? Because it's during this phase that all the sodium is in, potassium's out, calcium's finished moving, stabilizing, and everything's just about to reverse itself. If you have an imbalance of those electrolytes, then you can start to see changes of this ST segments and then further changes of the T wave that we'll discuss. So looking at the T wave, this should be a nice, smooth, beautiful, rounded configuration. Measurements, not really that important, okay, but amplitudes are important. We definitely don't want it too small, and you don't want it larger than the QRS. Definitely not, okay? So this area represents ventricle repolarization, okay? So this is when the potassium is moving back into the cell, past the cell membrane, and the sodium is moving out. We're using that potassium-sodium pump, calcium is being reuptated, magnesium stabilizing. It's all happening right now, that repolarization phase. So the amplitude should be dropping back down in order to get ready for that action potential to start again. Looking at the T wave itself, we need to think that this is the ventricle resetting itself before a contraction, so releasing that contraction. Now if we have inverted T waves, then that means that that part of the heart is essentially no longer viable, okay? It's dead tissue. You can have other things like peak T's, so you can actually have a really high pointed T's, and that usually happens when we have too much potassium. So remember, it's the potassium that's being drawn back into the cells during this phase. If we have too much, then we're still going to have that high amplitude, or that higher amplitude of pickup, which makes the actual T's look peak. Another thing that can be looked at before we move on to the end is the QT interval. Okay, it's not often spoken about, it's not often looked at, but this represents, unlike the PR interval that tells you a time that it takes for a message to get from the SA to the AV, this is looking at how long the whole process of depolarization, repolarization cycle takes for a cardiac contraction. Okay, so starting right at depolarization all the way through to ventricle depolarization, or repolarization, sorry, how long that whole process takes. Okay, and that should be upwards of 0.44 seconds. Okay, so up to 11 squares. A little bit over, don't get too worried, but if it's excessively short, or more importantly, excessively long, you have to start investigating myocardial problems. We'll talk more about that when we deal with arrhythmias themselves. So that's essentially how the whole PQRST complex works. Next thing we're going to move on to is steps that you can take in order to assess an ECG. Now I know you've all been through a whole bunch of these before in the past, so I'm not giving you the step that you are supposed to adopt. I'm essentially going to give you all the rules to look for, both a quick one and a slow methodical one. Because the idea is you'll take these steps away and you'll practice them. Because the more you practice them, the quicker you'll get at them. And then by the end of it, you'll find that you're just doing this sort of stuff automatically. You're not sitting there with a big book answering 10 questions and then going through it going, well, I know all the answers, but I still don't know what it is. It's just to train yourself to look for different things. Okay? So in no particular order, you can start with this, but I encourage you all to practice and then develop your own technique. Okay? So the first thing that you can do is determine the rhythm. Now what we're looking at with the rhythm is consistency. So right back at medical school, you heard all the people say, is it regular? Is it irregular? Is it regularly irregular or irregularly irregular? And you're just like, what on earth are these people talking about? What the hell is the difference? It's either normal or it's not. Okay? But there is a difference. So the way to test for regularity is essentially you can look at the P's, that's testing the regularity of the atrium, and then you can look at the QRS. Okay? Check the regularity of the QRS. So if you have the same distance between every QRS complex, then it's regular. If it's not, by any degree, okay, so if it's not consistently the same distance, then it's known as irregular. And later on you'll learn that irregular doesn't necessarily mean catastrophic. And that's when we start moving into the different pathways. Now you can get a rhythm that is regularly irregular. Okay, so every time something happens, like you breathe in, your heart rate increases. When you breathe out, your heart rate decreases. Okay, so that technically, when you look at the ECG, is what's known as an irregular. But it happens all the time. There's no negative outcome, so it's regularly irregular. When you get irregularly irregular, that's when you get your random PVCs. That's where you get your random beats, no correlation between P's and Q's, and there's just no consistency within the spacing between the beats. Okay, so that's what we're looking at, and that's the difference. I recommend that you always start with a QRS because it's just easier. And then when you look at the P wave as different, look at the intervals between the P waves as well, because that will help you determine certain arrhythmias. Now, the rate. Looking at the rate. So there's a few ways to do it. Okay, one, you can do it when you're dealing with a regular rhythm. So if you have a regular rhythm, a nice quick way to do it is to count the large squares in between the QRS and then divide that by 300. So 300 divided by 3 squares, you get a heart rate of 100. Okay, but obviously that only works if you have a regular rhythm. If you have an irregular rhythm, then you're going to get inconsistencies. You're going to get a pulse rate of 100 to the left, a pulse rate of 50 to the right, and you're not going to know. Okay, so from there you can use your timeline of your rhythm strips. Okay, you can count 30 big boxes, and that represents 6 seconds. And then within those 30 big boxes, how many QRS complexes are there? And then times it by 10. Okay, that's your rate. If you need to, if there is no association between ventricle and atrium, then you can get an atrial rate and a ventricular rate. But what you should always get is a pulse rate as well, because remember, this does not tell you cardiac output. This just tells you how much amplitude, how much cardiac activity you have captured on a sheet of paper. That's it. Next, we look at the P wave. We want to know if P waves are present, if the P waves are normal. So do they have that nice dome shape? Okay, and does the P wave always follow? Is it always before every QRS? Okay, so that's what we need to know when we're looking at the P wave. And note if there's any differences. Okay, if that's not the case. Step 4, we have a look at that PR interval. So remember, that's the time it takes to get the message from the SA to the AV node. Okay, easy enough. So we count the little squares in between from the start of the P to the start of the QRS, and then you multiply that by 0.4. Now, a normal one, remember we said, is 0.2, up to 0.2 seconds. That's your PR interval. So you want to know what it is, if it's normal length, and then if it's consistently normal length as well, because that will help us determine arrhythmias later on. Okay, step 5, you need to have a look at that QRS complex. Okay, make sure it's there, and then look at the wideness of it. See if the QRS comes after every P wave, and is it less than 3 squares? Are the QRS the same size across the board as well? Do you have a random, large, spread out QRS complex, or is it consistently the same size and shape throughout your ECG? Okay, we'll talk more about QRSs when we move into arrhythmias, but right now we're just looking at it. Are they present? Are they the same? And are they less than 3 squares? It's the main thing we need to know when dealing with QRS complexes. Step 6 is we look at the T wave. Are they there? Are they normal shape? And do they follow the QRS complexes? Are they spread out? Are they peaked? These sort of things that we're looking for. Step 7, we go back and we look at that QT interval. We want to know if that QT interval is shortened or lengthened. Okay, is it less than our 11 squares? Okay, that's what we need to know. So remember, that's the start of the QRS all the way through to the end of the T. And then our final step is we evaluate. We look at everything that we've got. Okay, we look at the ST segment for elevation or depression, and we look for general abnormalities like peaked U's, peaked T's, depressed changes, P waves that are upside down, anything that doesn't look normal to a normal ECG, and we note those down. We look back at our notes that we've written about this ECG, and we try to get an evaluation of what's happening. Now, if you don't know what's happening, that's fine. Okay, report your findings of the ECG, and also import your findings of the patient. Does these changes in the ECG represent physiological changes in the patient? Are they perfused? Do they have sufficient output? Do they have pain? Do they feel nauseated? All this sort of stuff. Okay, don't just give a handover for an ECG, give a handover for a patient as well. Okay, so that's the 8 steps that you can go. As you can see, quite long. This is what we do in practice. Always practice, and then we get used to it. We don't do this in an emergency. Someone's on the table and they're in an acute state. We definitely don't do this. This is what we do at practice time, or when we have the time to hand over a good. So you've got a good medical case, someone's got a slight electrolyte displacement outfield, you've done an ECG, you have time to look at the lead 2, and you want to report all these changes. This is when, non-emergent situations. Once you translate to emergent situations, then we start looking at a more simple, rapid method. Okay, now this ALS2 Simple method put out there, and it essentially looks at problems. So straight away, what is the problem? We're looking at the ventricles, because it's the ventricles first that are going to cause the biggest problem in the output. So first question we ask is there electrical activity? Because if there's not, we need no more question. Why are we looking at anything else? Okay, straight on CPR, that's a system. Then we look at how fast the rate is. Is it fast? Is it slow? That's the main thing we want to look at when we're looking at the ventricular rate. Looking at the QRS rhythm, we want to know if it's regular, irregular. When looking at the QRS, we definitely need to know whether they're prolonged. Is the QRS narrow or is the QRS wide? That's all we need to say. And then, is there atrial activity? Is there any signs of P waves? And if there is, does it relate to ventricular activity, and how? So that's the method. Now the reason this method's in place is because this quick 4, sometimes 6-step method can help us correlate quickly to cardiac emergencies. So you can hand over quickly that you have an irregular narrow complex tachycardia or an irregular broad complex bradycardia, and they will correlate to algorithms that have been made for adult tachycardia and adult bradycardia. And as you will see, it's a lot quicker than going through those steps. So from this particular one, start practicing your method of interpreting ECGs. So have a bunch of lead 2 ECGs that go through the process. Take the time now while you've got no patient to hone in your process, hone in what sort of things you're looking at. Use the cheat sheet for starters. Always use the checklist if you have to. But then fine tune it down. You'll know that some patients you don't need to look for everything, whereas other patients you will need to get a full detail on everything that we've spoken about. So learn the difference, practice it, and let us know if you have any questions. And until next time, take care.